Hello, everyone. This is Asan Hussain. I'm an assistant professor uh, at Dalhousie University in Halifax, Nova Scotia, at the Department of Ophthalmology and Visual Sciences. Today, we'll be going through our oculoplastic case, so we'll jump straight in. This is a case from my fellowship when I was in Toronto at Sick Kids. And this is a young girl. I believe at the time she was about 6 years of age, who presented with really quite a severe proptosis and swelling around the eyelid region, which had worsened, according to parents, in the last week. So almost like a catastrophic change with sudden onset worsening of the swelling of the eye. So that immediately makes you think of, as per some of the other cases we've discussed, of possibly a vascular origin. And in fact, if you look at the medial part of this young girl's eye on the left side, you'll see a bluish hue to the skin, maybe determining that there's been some bruising there or chemosis, and possibly an underlying vascular lesion. So what happened here is that this young girl actually began to present with symptoms of optic neuropathy and required drainage of her venolymphatic malformation. So that's what we're going to talk about today. Um, this is not the same patient. I'll let you figure out why it can't be the same patient. But anyway, uh, this is an MRI, just axial views shown here. On the left, as you look at the screen, is the patient who's before treatment, and on the right is after treatment. But we'll come to treatments and the presentations of venolymphatic malformations or lymphatic veноmalformations in a moment. So, what are these lesions? These are benign and congenital vascular
Oh,
malformations.
sorry. Sorry, there's like some sort of like scratching or sound or something there.
So, what are orbital venolymphatic malformations? Well, these are rare, benign, congenital vascular malformations. And these lesions may be present at birth, but generally they do not become apparent until infancy or childhood. And they usually can present sometimes in patients with an upper respiratory tract infection or trauma, which leads to, as in this patient, an acute intralesional bleed in some cases. The commonest presentations are with proptosis, with ptosis, with swelling of the periorbital soft tissue, and restriction of eye movement. That can be combined, of course, with signs of optic neuropathy if they are significant enough. Now, there are various classification systems of LVMs. These lesions are categorized into no flow to slow flow lesions based on the recommendations of the Orbital Society. Um, in terms of their location, they can be grouped as superficial, deep, combined, and complex. Uh, and Rubin et al. In their paper considered that the hemodynamic effect of size and type of inflow and outflow channels is important in determining how you will treat these lesions. Now, these lesions have a variable venous and lymphatic composition. Some are combined in terms of having fairly equal contribution from both systems. Some can be purely lymphatic, and some can be dominant, can be dominant venous, with a large venous outflow to the systemic circulation. And really, the only way you'll know which one it is by, of course, doing imaging, which has to be contrast enhanced, and you'll need to order the appropriate investigation. If you do perform surgery on these in terms of excision, which is rarely done these days, you will find histologically multiple dilated sacs and lobules lined with a single layer of endothelium containing either proteinaceous or serosanguinous fluid with smooth muscle bundles and dense lymphocytes and follicles, and of course, sometimes hemorrhage. So I'm just going to quickly come to now management. Now, these are intraorbital venolymphatic malformations and arteriovenous fistulas can be very difficult to diagnose and manage. The reason is that the anatomy is not well defined. If you perform surgery on them, you can easily damage critical structures around the eye, leading to blindness or other complications. Um, if there's a history of trauma, you should always be thinking about possibly is there an arteriovenous component which can actually coexist with a venolymphatic malformation. And sometimes you will need some dedicated vascular studies to make sure that you are going to be safe when operating if absolutely necessary. There are some reports of people using glue and also coiling these lesions combined with interventional radiologists before the lesion is excised in toto. Um, these, as I've mentioned, lesions are irregular, they're infiltrative, and they involve vital structures of the orbit. They have rich vascular beds, which can lead to uncontrolled bleeding intraoperatively. And they may also have no accessible vascular channels for, endovascular approaches. So in most cases, if you have a patient presenting to you with a history of proptosis and one of these lesions, it might just be best to observe. If the patient's having no neuropathy or other complication, your safest bet maybe is just to observe. However, we are now beginning to see some new non-surgical strategies. And this patient actually underwent sclerotherapy, which is the use of bleomycin in the case this case at sick kids. There are other chemicals such as sodium moroate, sodium tetradecyl sulfate, doxycycline, and pingenmycin. This patient ended up having bleomycin, and that was injected by the interventional radiologist under direct visualization. She had, I believe, about 4 or 5 treatments until the lesion basically completely resolved. And she had an amazing result, as you can see. Here she is about, I think, 18 months down the line. So in summary, I'm just going to say that venolymphatic malformations are slow flow lesions with either a predominant lymphatic, predominant venous, or mixed picture. As with any vascular lesion in the orbit, they can present catastrophically or suddenly with bleeding into the lesion. If vision is compromised, some intervention may be needed. And in fact, that picture I showed you earlier with the bruising is where this lady had some drainage done of some blood from the lateral orbit. You can see some chemosis and bruising there where we entered the orbit and drained some blood to reduce the pressure on the optic nerve. That, of course, is not a treatment of the condition, but it's a sight-saving procedure. In terms of management, I would suggest that observation is key, but if you feel that you have to intervene, I would reach out to your interventional neuroradiologists and look at the various options, and then possibly look at doing that as a combined case with them, and leave surgery in terms of open surgery as a last resort for these patients if absolutely necessary, with, of course, the caveat to the patient that the surgery in itself might make things worse, because this is a very tricky lesion to deal with from open surgery. I would also mention that preoperative planning is very important. So always get the correct studies. You will need an MRI. You will need contrast, such as gadolinium. You will need a certain fat suppression techniques, and these are all things your radiologists will guide you on. Okay, that's the end of that case.